So this next session is on the importance of patient and carer involvement when we're thinking about designing any kind of interventions to improve services. And it's essential, really, and it's an essential thing that we need to think about. And I am going to talk a little bit in the first instance, and then I'm going to hand over to one of our highly esteemed public contributors, Liz, who's going to talk way better, more eloquently than I am. So I'll just go on. Okay, so first of all, I'm going to talk about patient and public involvement. Then I'm going to highlight some really helpful resources if you're starting to think about patient involvement. Then I'm going to briefly talk about some considerations for when we're doing involvement in kind of sensitive topics. And I'm going to hand over to Liz then, who's going to consider 6 key questions. Oh no, we don't like the word key, do we, Liz? Six questions. Okay, so what is PPI and PPIE? Okay, well, there's a lot of different words that people use, and Liz will talk a bit about this in a minute. So people say patient participation, participation and involvement, participation and engagement, and then there's different things that people say, so co-design, co-production, all those types of words and terms. And sometimes those terms refer to the level of involvement that when you're involving people. And obviously from our perspective, we like, irrespective of the term, co-production models where people are involved throughout the full process. Okay, so why is it important? And I'm only going to briefly talk about this because Liz is going to go into more detail. It's important because when we involve patients and carers and staff as well, it makes sure that we're shining the spotlight on the right places, and that we're asking the right questions. We're asking them to the right people and in the right way. And ultimately, it helps to ensure that anything that we do design and any plans that we make will translate much better into actual practice, and they will work to a better capacity in practice as well. Okay, so we have some resources. So these are some resources that are online, and we have them on our website. And if you're thinking about patient involvement, highly recommend them. And I'm going to pull a couple of things out of them now in a minute to kind of show you how useful they are for when you are planning patient involvement for quality improvement. These two here are from HQIP, and they give really good details about patient involvement and really practical steps on how you do it, and give worked through kind of best practice examples of patient involvement in quality improvement studies. And this one here as well is about setting up a panel for quality improvement. And we can also share our own advice and things that worked for us as well. And this is another really good one as well. In research, we use, and there's a lot of parallels, they overlap a lot, quality improvement and research anyway, but involve are kind of the best practice that we have for patient involvement. And they also have a set of standards for involvement in research that we use, and we have them as a standard. One of the things, and this resource that they have, this knowledge base, is fantastic. It gives so much information about how to do involvement well and meaningfully. And one of the things that I think is really important is pay and money. And I don't think any involvement should ever take place unless people get money. And you know, it's about more than money. It's about value, and it's about their role as well, and it's about equality. And Involve have a set of standards around remuneration, and they break it down for task as well. So I'll highly recommend having a look. And if anybody ever wants advice on money and how much to pay, just please do contact me. This is from one of the resources, okay, and it's kind of the how to involve people, and it's from this resource here. And it's based on the Plan, Do, Act model of quality improvement. and it gives the steps at each way. Okay, so it's what are you aiming to achieve? So have patients been involved in choosing them? How will you achieve your aim? So is it part of the patient's journey? Have you decided to involve the resources that you need? That's where pay comes in, training and support. We have huge investment for our public contributors around training, support, time and pay. Then the arrangements, and then how will you create improvement, and then evaluating and informing them. Okay, so it's a really helpful kind of flow chart to think about involving people at every stage. This is another similar one that's taken from the HQIP one, and it's another kind of flow chart that I quite like. And it has the first one, so when you're preparing and planning kind of projects, so is the area important to patients? And that's where you need to involve people at the start so they can help prioritize areas to work on. Then the data collection process. So this is involving people in that process. And those resources, they give really good examples. So they have like where patients themselves are conducting interviews as part of the process. And just as Emily said there a couple of minutes ago, people might open up better if there is a kind of a peer model when it comes to quality improvement as well. Then another thing, the third stage here, so having patient champions take forward recommendations. And here having patients presenting reports as well and promoting projects. And then again, feeding back into the cycle. All the things that I've mentioned now are on our website, and all the resources are here, and the website is here, and we'll send this out in an email as well for people. So they're absolutely really helpful. And also with Liz is going to talk now in a second, but we have a very established patient involvement group, and if anybody needs tips or strategies on it, please do contact us as well. Okay, so now I'm going to hand over to the fantastic Liz, and Liz is going to talk about 6 questions for when you're considering patient involvement. So Liz, I'm going to hand over to you.
Thanks, Leah. It's been really enjoyable hearing who's here at the meeting and hearing from Emily about wonderful battle scars. My name's Liz. I'm part of a lived experience expert reference group for improving community services for self-harm at Manchester University. And I'm also a research champion at Leeds Teaching Hospitals Trust, and also a CQC expert by experience for mental health, learning disabilities and autism. These talks often start with some big data, and we've hinted at it already. We know that calls to mental health helplines have increased massively through the pandemic, and that forecasts are that millions more people might need extra mental health support. Add to this knowledge the 8.5 million people with existing mental health problems. And this big data is great, but it can be difficult to capture different population health needs, which is where the small data of individuals' experience comes in. It's in the small data that shines a light on the gaps and weaknesses of services. My own small data is certainly not small for me. My lived experience is as a suicide and self-harm service user and survivor and carer. 2 of my 4 children experienced self-harm and suicide attempts as adolescents. So I'm going to talk about 6 things you could think about as you develop your services. And they're quite straightforward, those journalist questions. The why, who, what, how, where and when of good PPIE. First, the why. You may have heard of that phrase, nothing about us without us. And you might know it grew out of a disability rights movement in South Africa during the years of apartheid to convey the idea that no policy should be reached without the full participation of representatives of all stakeholders. More recently, it's been adopted by patient communities worldwide wanting to improve healthcare systems, and it's become a valued and necessary part of the way services are developed, so they become more representative and therefore more valid, more meaningful through recognising the complexity of people's lives and by hearing stories of people's lived experience. Second, the who. Who might these important people be? Well, you may have heard about so-called hard-to-reach groups, chaotic families, problem people for society. The people who are so often judged and stigmatized for the complex health and social issues that they have to live with. The gap between rich and poor in this country is growing, and it's not just an economic gap, it's a health gap. In my city, people who live in better off areas live more than 10 years longer than people who live in poorer areas. And these differences aren't new. They've been studied and written about since Victorian times. What's new is that we now have data, evidence of what can make a difference to people who experience health inequalities. And it's known that one of the best ways to make differences is by involving the people who live at the sharp end of this wedge in improving services which are there to serve them. People with lived experience of services can bring real meaning to service development. And you might not realise, but by taking part in meaningful PPIE, it can be empowering for both individual people and the communities they come from. Acknowledging the expertise of people with lived experience of services can help shape understanding, build knowledge, inform practice, and improve patient safety and experience, as well as shifting public attitudes. We take this participation pride back into our lives and communities. Some of our group have spheres of influence and action, networks of support, but for others, just being welcomed as part of a group is enough to enable a sense of self-worth, recognition that your worst experiences can help bring about positive change. Third, the what. There may be difficulties in reaching out to and welcoming in and listening to people who've had negative, even traumatic experiences of services, just like the people I mentioned just now. People who've experienced mental health services may have lived with stigma, their own and society's, even discrimination. And this isn't helped by persistent negative portrayals of mental illness in the media and a healthcare system which has recognised structural inequalities. They may never have been asked about their views or experiences of services. They may find it hard to believe that you will listen to them and not judge them. They may have difficulty trusting you if they've been let down by services in the past or now. So with that in mind, on to the fourth, the how. How do you build relationships of trust and respect with these people, so that you can learn from them about the contexts and implications of the range of their experiences, some of which may be negative. It requires all the things you bring to any relationship: time and commitment, loyalty and honesty, generosity, acceptance. The benefits of this to you as service providers will no doubt be obvious. The validity and meaningfulness of your work will immediately be more relevant and more representative, based on real lives, strengthened by treating your PPIE people as colleagues on the journey to self-improvement. And a gentle reminder here, though, that one size PPIE does not fit all. Different strokes for different folks. The academics and clinicians at the University of Manchester know our lived experience group well. They've spent time getting to know us as individual people, not just patients or members of the public. We've grown to trust them to really listen to us. They ensure our safety through these sometimes difficult encounters, and we've each prepared a well-being plan so that they'll recognise if any of us are struggling, because as you can imagine, some of the work we do can be triggering. They hold us carefully, and they never shy away from hearing our pain. They recognise that our insights and perspectives can bring new lenses to their understanding. So fifth, the where. When our group first met, the pandemic hadn't happened yet. So we used to meet face to face with tea and coffee and sandwiches and cake. We had time to catch up with what we're all doing, and friendships grew as we got to know each other. Since the pandemic, we've been holding online meetings, making sure that everyone who wants to can still take part, whether it's by phoning into meetings or making sure people have the right tech and know how to use it. In other words, addressing the digital divide. We were even able to include new members to our group who lived further afield and might have found travel difficult. We know people may find participation hard, so we let them do it on their terms with flexibility. No camera if they prefer, taking a break when they need one, and checking their well-being straight after the meetings. By taking engagement out of your settings and into the big wide world, you can reach many more different people. These slide photos were taken by members of our group to represent the theme of hope, and they're part of exhibitions held on World Suicide Prevention Day. In 2019, we set up our gallery in the city centre of Manchester and spoke with many and diverse passers-by, from council officials to homeless people, tourists, cleaners, visitors and shoppers. We had conversations with these strangers about suicide and self-harm and found they were interested in understanding the research that goes on at Manchester University. We heard stories of people's experiences and hopefully help destigmatise suicide by normalising conversations in sensitive and careful ways. We made it onto the news too. And last year we had our exhibition online, and so far over 1,000 people have had a look. Finally, the when. Well, addressing local health issues and health inequalities is vital, as the data shows the growing gaps between the health haves and have-nots. And you play a really important part in this. By involving people with lived experience throughout their service development, design and delivery, you're building meaningful and long-lasting relationships within communities. You're developing community capital, enriching communities by including their people from the get-go and throughout the development and delivery process. These webinars will give you helpful resources and hopefully some inspiration as you and your teams improve community self-harm services. You might have been expecting those different keywords in this talk, like co-production and inclusivity. These are words which a lot of us find a bit abstract, a bit slippery. You might wonder what they really mean in your stretched and pressured work situations. But in a way, it's simpler. It's about becoming someone who thinks about how to do things fairer, kinder, safer and more helpful for, and importantly with, the people we care for and care about. Ultimately, it's about what kind of society we want to live in. So finally, please don't forget to thank your PPIE people who join with you to improve services and celebrate their participation. Because by being part of the process of designing more inclusive and more responsive services, they've become part of something bigger. Thanks for listening and good luck with this important work.